Oops. It is raining outside, so I had to take a peek at the rain. Alrighty. Tonight, we're going to be talking about risk adjustment coding, because this question keeps coming up. What is it? Why it's a really good idea for new coders? And hi, Yvette. Thank you for the blue hearts. And we're also going to be talking, let's see, what else was I going to say? There was another thing I was going to talk about tonight. It was risk adjustment. What else? There was something else I was going to cover. Oh, what is it? Non-paid internships and what I think about them. Hi, Christina. So we're going to be talking about that tonight. So risk adjustment for new medical coders and why it's a good place for new medical coders to start. What is it? I'm going to be leaving a link for a very good article that is going to describe it a lot better than I can. But it is really good reference material if you're interested in it. It's one of those things. It hasn't been around too long. I mean, it's been around since like 2013. They were saying back in 2013 they were saying it was relatively new. Okay, so it's been gaining popularity over the years. So it's just a matter of time before things gain traction. But I'm going to read this. I'm going to read part of the article from For the Record magazine. So when we get started here, and if y'all hear thunder, it's because it's raining, like with lightning and everything. So hi Tish. Hi Sandra, and hi Aurora. Thank you all for joining me. All right, so since we have a good little crowd here, let's go ahead and get started. If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. If you are a brand new medical coder out there and you're wondering what positions can you apply for as a medical coder, risk adjustment was one of the ones that I talked about last night. So when you're a brand new medical coder, yes, you're going to see a lot of positions that will say we want the coder to have at least 1 year of experience, sometimes 3 years, sometimes 5 years of experience. And a lot of these employers are holding steadfast to that. They're like, we want this is what we want. But it doesn't necessarily count out new people. You have to be persistent and you have to apply anyway, even if they are asking for 1 or 3 or 5 years of experience. If the position is for coding, you've been trained in coding. They may take a chance on you if you have a very well-written resume, if you have a very well-written cover letter. So something to keep in mind. But risk adjustment is one of those other side positions that can lead you to being a full-time medical coder. Risk adjustment coders, the definition, if you will, from For the Record magazine. It says risk adjustment is a process of collecting all diagnoses codes from patient charts and using these illnesses along with their comorbidities and complications to determine ICD-10 codes, which drive risk, ICD-10-CM. Diagnoses codes are a good starting point for analyzing known conditions and speculating on potential risks. So for those that are new, this translates to these coders are only coding just the diagnosis codes. They're not doing procedure codes. They're not doing evaluation and management coding. Before you get excited, risk adjustment is a good place to start because this is going to get your foot in the door somewhere. This is going to get you starting to get familiar with the anatomy of a record, right? And it's getting those diagnoses, like mostly on inpatient charts, right? And so you're looking at those. You really do need to kind of understand what's happening. I've gotten questions from risk adjustment coders all the time who are kind of lost on the disease process. And what about this? And what does this mean? You do have to understand what's actually happening with these diagnoses. So even though you're not doing procedure coding, you're still having to really have an in-depth understanding of diagnosis coding. So you're not off the hook, guys. You got to make sure that you are really kind of thinking about that. So from this article that they have here, and this is a really well written one. It's just kind of long, and I don't really want to go into it too much because, like I said, it's a lot of words. So what I'm going to do is I'm going to leave this in the dialogue box, and I'm going to leave it in the comments too, so that way you guys can check it out, bookmark it, and that way you guys can read it in its entirety. And guys, when I give you material to look at, check it out, because there's a lot of really good information out there. Hi Miriam. Oh, Las Vegas. I miss Las Vegas. Thank you for the blue heart. I miss Las Vegas. I used to go every year since like 2014. I went every year without fail. However, this pandemic makes it a no-go for right now. But when I do get to go back there, I love going there. Hi Mitney, I'm doing great. Thank you, Jamie, for the blue heart. Okay, so you must be new to my channel. We don't talk about money on my channel. That I always tell you guys to check out the local job listings in your area, because people are watching this from all over the world. This video, they're watching it from all over the world. So I never like to give money in numbers, in specific numbers, because of the simple fact that it's different everywhere. And so what you may take from my channel and be like, oh yeah, well, she said, no. My channel is for what is medical coding, what is it about, and medical coding itself. So again, check the job listings and do your research. There's the Bureau of Labor, the Bureau of Labor, and then the Bureau of Statistics. So that way you can look in your area and it'll tell you, in the Bureau of Statistics, it'll let you know what a medical coder starts off at in your area, whether it's risk adjustment or, whatever's regular coder, it'll let you know. But yes, so that is pretty much what it is. The hierarchical, they also will call it HCC coder, risk adjustment coder, /HCC coder. If you have the Optum 360 coding book, the ICD-10-CM coding book, in the back, in the appendix, it has a whole thing about HCC coding. Let me see if I can bring it up. In the appendix, where is it? The 3 characters. Is it in here? I thought it was in here. It's got to be, yep, there it is. Okay, so in Appendix E, if you have the Optum 360 ICD-10-CM book, they have a whole thing about the Centers for Medicare and Medicaid Services hierarchical condition category HCC coding. So that's the risk adjustment, and talks about the risk adjustment model. The primary purpose for risk adjustment model is to predict, on average, the future health costs for specific consortium enrolled in Medicare Advantage health plans. CMS is then able to provide capitation payments to these private health plans. Capitation payments are an incentive for health plans to enroll not only healthier individuals, but those with chronic conditions who are more seriously ill, by removing some of the financial burden. The MA risk adjustment model uses HCCs to assess the disease burden of its enrollees. HCC diagnostic groupings were created after examining claims data so that enrollees with similar disease processes and consequently similar healthcare expenditures could be pulled into larger data set in which an average expenditure rate could be determined. The medical conditions included in HCC HCC categories are those that were determined to most predictably affect the health status and healthcare costs of any individual. Several important principles to the risk adjustment model and the development of the HCC categories include, but are not limited to, and then it talks about the HCC diagnostic categories. I was going to say condition categories. The HCC diagnostic categories should be clinically meaningful. The HCC categories should predict medical expenditures. The HCC diagnostic categories should have adequate sample sizes, and discretionary categories excluded to be as accurate and stable in their estimate of cost as possible. The HCC diagnostic categories should be both hierarchical and additive. And the number 5, the diagnostic classification should encourage specificity and should not reward coding proliferation. I don't know. It says that word, but I think it's proliferation. There we go, proliferation. So that's what it says. And that's just part of it, but the rest of it is it's a lot of words. So I don't want to bore you guys, but it does cover it front and back. And it talks about documentation tips and things like that to what you should be looking out for as the coder. So that is very interesting. And then of course in Appendix F, it talks about the Centers for Medicare and Medicaid Services Quality Payment Program. So that is something that you can look at. These are other resources to kind of help you understand what is actually happening when you get into these types of positions. But these positions are good for brand new medical coders because, you know, a lot of times they're not even asking for experience. Sometimes some employers are not even asking the individual to be certified. I've seen many not ask for the individual to even be certified to be a risk adjustment coder, which is worrisome because you really do need to kind of have some kind of understanding about diseases and some kind of understanding about these codes to be able to select the appropriate codes. Hi Miriam with the hearts, thank you. Hi Beth, good to see you. Hi Misty, thank you for the blue hearts. Hi Guy, a good day to all, and of course Miss Blue, thank you. That's a barn burning paragraph. Yes, it is. It was a lot to read. And plus it's a heavy book and I was in an awkward position too. Trying to hold it up. But hi Karen, hi Blue, I hope you're having a good day. I am. It was a very busy day, very good day. So I would say it's great. It's just raining right now. And while it sounds very nice when it's calm, it has been thundering out there as well. So I took my test on Saturday and waiting for the results. You and 2 others. I am waiting for y'all's results because I have been anxiously awaiting. And so I know 2 of them are supposed to hear by tomorrow at least. I'm excited. So if you are out there and you've taken your exam and you are at that point where you're just kind of sitting and waiting to see what happens, of course, it's going to seem like an eternity before the time gets there. I'm a nervous wreck. I'm sure you did great. But whatever happens. Your journey is your journey. Everybody's journey is going to be different. And for some, you know, they get the results and boom, they're ready to go. But it really all depends. And you have to walk in faith, whether you get your certification and you pass it right away, or you get you need to try it again. Either way, you got to walk in faith because it is a journey. It's a marathon. It is not a sprint when it comes to this industry. Raining here in Dallas too, yes. And you're welcome, Beth. I'll be waiting. I'm so excited. But another question that keeps coming up that I want to talk about is these unpaid internships. I keep hearing about them. I hear about them all the time on LinkedIn. And oh yeah, these folks that say, well, you know, we'll get you experience, we'll get you training, but this is an unpaid internship. People are asking me, do I think that it is worth it? Should they do it? Okay, so everybody's journey is different. Everybody, you know, has different things going on, and I understand. Well, I have bills to pay, so I can't work for free, and I get it. Personally, I don't think that it should be an unpaid internship, especially for medical coders, because we are technically trained. So while maybe there's people who are saying, well, we'll teach you, but they're actually having you code actual records just so that you can get the experience and things like that. To me, I still don't think that that's a good thing, because somebody's paying them, right, to get those records coded. So even though they're teaching you, you shouldn't be working for free. At least that's what I think. To me, when I see that, or when I see the pay for new degree holders, like RHITs, when I see what they want to pay these RHITs, it makes me sick. And I really want to be like, okay, are you really serious that you want to pay somebody who has a degree that amount of money? Like that's an insult. It's an insult, and into the fact that you've spent that money to get that degree, and then they don't want to pay you. No, you can take your talent somewhere else. Because while they say, well, you know, Bleu, it's really hard to get, you know, anybody to take a chance on you. It is. In the beginning, it is. And as I mentioned last night, there are some alternatives. You can get into risk adjustment. You can go in through medical records, and while the medical records is not coding, it is going to get you around the people that are going to be hiring for the coding. Same thing with risk adjustment. It's going to get you around those people that are hiring for the coders. People who do prior authorizations, that's actually looking at the record, and that's actually being able to telling the insurance company, hey, this provider wants to do this procedure, and the patient has this diagnosis, and, you know, can they do a yes or no? Well, no, that does not support that procedure. And so then you have to go back and talk to the doctor and that kind of thing. But it's getting you around the diagnoses. It's getting you around the procedures. So getting in through prior authorizations is another great title to look up for when you're looking for medical coding positions. So it's not only just going to be listed under medical coding positions. It's going to be listed under different things. Sometimes it's going to be listed under health information tech, medical records tech, and then as you read the job description, it is going to be talking about like what they do and their duties. So paying attention to those things is really key, really key. That is a very good question, Kung Fu Ken. I like that. Hi, Blue. I want to ask, when and how do physicians learn how to document? It feels like it's definitely not taught by HIM professionals. It's not. They learn this in medical school. Sometimes. I did an interview with Dr. John Lin a couple of years ago now. And he was, as we were talking, he was like, well, where did your physicians learn how to document? And I said, well, they said that they learned a little bit in medical school. And he said, well, when I went through medical school, we didn't have that. So basically they're learning from their peers. They're learning from whoever their senior doctor is on how to document. And you'll hear that. We have PA rotations that come through there, and nobody teaches them either. At least not somebody from HIM is not teaching them how to document either. So this makes me crazy, because every time, and it never fails, when the PA students come through the clinic, they come through and they're like little tornadoes because they go and you see what they're documenting, and I'm like, are you kidding me? Like, why are you not documenting laterality? That doesn't make sense to me. That should be common sense. You are the physician, you're the physician assistant. You should be knowing that you have to document laterality. You have to document what the patient is there for. Well, I can't diagnose a patient. I'm not telling you to diagnose a patient. What I'm saying is this: when the patient comes in and you're documenting, the patient has pain in their left ankle, okay? Not patient pain. Patient pain where? Patient paying what? Are you getting paid only by so many words? I mean, like, dude, what are you doing? But yes, this makes me crazy. This is what I've always loved to do, is teach providers. What I've always wanted to do is catch them when they are in residency, because that's like the best time to catch them, because that's when they're not going to be developing no bad habits, right? Because by the time they get out and they're, the attending, they're going to know how to document. It's not going to be like, oh, they get out of residency and then, oh yeah, I'm an attending now, so now I'm going to learn how to document. That's what you have to go through, because basically that's when I'm getting them. They're out of residency and they're attendings, and I see some of the things that they're missing, and I'm like, okay, I have to query you for this now. Well, why am I getting a query for this? Because you're not telling me which side. They had a femur fracture. Okay, femur fracture where? Because there's two, left, right. I mean, which side? And like, I forgot. So let's not forget, okay? Let's not forget, so Bleu doesn't have to query you. But yeah, they kind of learn anywhere and everywhere that they can, which I think is horrible. I think in medical school, they should have a whole class in how to document. And it shouldn't be taught by another doctor. It should be taught by an HIM professional, somebody who is a coder, who knows, not somebody who has their degree and has never been a coder, somebody who's actually been a coder and said, okay, this is what I've seen in the real world, and this is how you can avoid all of that. This is why we need this. And not teaching them to like they get all these high levels, but no, teaching them so that they can be detailed, because a lot of times their question is, why do I have to have this detail? It's like when they say they document the patient has anemia. Well, there's a bunch of different kinds of anemia. So which one do they have? And then based on what their documentation says, what are you trying to say here? Well, the patient has anemia. What is it? Iron deficiency anemia? Is it blood loss? What is it? And so that's when the detail comes into play. But that's why they have to be taught this, and they have to keep having it repeated, because they're out of school already. They think that their school days are done, but in actuality, it's not. So the best time to get doctors would be when they are in school. At least that's just what I think. Because then that way you have full and complete documentation the entire time. Because even when they are students or they are residents, I still say it's not an excuse. If they are missing things like laterality and things, there's no excuse for that. If they're doing any kind of procedures, let us know. What are you doing? And they have manuals that say what these procedures all entail. And I know they've watched these doctors put together their op notes, so they have an idea of what these, op notes are supposed to look like. But what happens is a lot of times sometimes coders don't feel confident enough to go and talk to these doctors. And then sometimes it is one person, and that person maybe doesn't have a real hands-on approach. Maybe they only talk to them at certain times. And so a lot of times the communication doesn't come into play. You have to have really good communication, whether you are just a coder or you are the lead coder or the supervisor or whatever. You still have to have really good communication, and especially with these providers, so that they can learn about proper documentation. At least that's just what I think. And then you have those doctors who are willing to be educated later on, and they're willing to actually pay to take a course. But then you see them arguing with the instructor, like, why do we have to have this? There's things in this book, in the ICD-10-CM book, the CPT book, the ICD-10-PCS book, and the HCPCS book, that do not make sense to them. And when they look at the way that these codes are written, they get confused even more. And so it's like, they said, well, I don't know how you do it. Like, I don't get this. And I was like, well, that's why I know the rules, and I'm here to help you out. I said, that's why when I'm telling you, when we're educating you, when you're getting this information from reputable resources, that's when you have to really start paying attention. You can't just listen to your colleagues, because sometimes your colleagues are not always trained the proper way either. And sometimes it's because they're doing it their way, because their coder is not strong enough to come and tell them, hey, you're actually doing this wrong, because there's no detail here, or this procedure is not supported by your documentation. It's actually this other procedure that I'm changing the code to because this is what is reflected in the documentation. Sometimes coders just don't tell them because they don't want to get yelled at or they don't want to make the provider mad. It's not about that. When you start learning how to be that team, cohesive team, and when you have the providers who understand that, and when you have coders that understand that, and they actually actively work towards that, that's when you start having the magic happen. But trust me, it's not easy. I have a new provider who made me think back to the day when I was very first starting this and I very first started learning how to communicate with providers. Oh yeah, he's giving me a lot of good flashbacks, He's gonna take some work. He is gonna take some work, but it's okay. I am up for the challenge because that's what I do. And I said, okay, this reminds me of back in the day. What did I do back in the day? Because everybody accepts what I say now. When we start talking about like the new E&M guidelines back in January, I started telling them right away. You know, it was hard for them to kind of break out of that. They're not used to that. Oh, I don't have to document all of this points now. And I'm like, no, you don't have to do that anymore. It's got to be problem pertinent or, you know, whatever else going on with the patient. Wow. And they were happy about that. But it takes me to have to go and explain it to them rather than just them hearing it from, oh yeah, well, we code it this way because my facility does it like this from their colleagues. So I always tell my providers, when it comes to listening to other people, you need to listen to me. I'm your coder. If it's something that you're hearing from another facility, another doctor, another facility, yeah, that may apply to them, but it doesn't necessarily mean that it applies to you at this facility because different facilities have different rules too. And sometimes it's with different insurance carriers. So the variables make things different, you know. Hi, Hannah. Thank you for the blue heart. I'm anxiously waiting for your results as well, too. But I can't wait. But yes, not to stray off the topic of working for free, but I don't recommend working for free. I don't recommend doing the internships where you're not getting paid. Well, Blue's giving me experience, yeah, but somebody else is benefiting off of you. And you've been technically trained. So keep applying until you get in somewhere. And even though they say, well, you know, we'll make sure that you have all of this experience. And I've actually heard of some people charging for their internships, which is, again, not right. But I wouldn't pay somebody to get experience. Why would you do that? I don't understand that. Like, I don't even think that's right. That's no. Let me pay you for my experience. No. I would rather work as a biller than do that. I would rather work in risk adjustment than do that. I would rather work in medical records than do that. Now, one thing I will not do as a brand new medical coder is do scheduling, because that has nothing to do with medical coding at all. There's no avenue out from that. And sometimes people kind of get stuck there. So you have to be careful with these positions. Release of information will get you around people who hire. And that's a lot of like HIPAA, right? Because we have to be trained in HIPAA, right? So you are qualified for that. But again, you want to make sure that you're spending your time there just to get the experience and just to get in. It's not going to give you coding experience, but it is going to get you around those people who are going to be doing the hiring for the coders. So that's just another alternative that you can go through. There's a lot of ways to get in. Revenue integrity, they call them sometimes. So that's another position you can look under. It's not just medical coder. You know, you have to be open for anything. And applying with these temp agencies. You know, I had somebody yesterday who commented, well, you know, I have bills I got to pay. Well, I had bills I had to pay too when I applied at a temp agency. But that temp agency job landed me a 3-month assignment, 3-month steady assignment. And there was like 2 other ladies that got hired at the same time too. And we were basically competing with each other because they were only going to keep one. We were working on their backlog. So I didn't get picked and another lady didn't get picked. we have technical ability, so that wasn't it. You know, I think it was just the supervisor herself, but you know, I wouldn't want to be under her anyway. And that led me to another position, which I had for another 8 months. And that led me to my position, my permanent position here. So this permanent position here had nothing to do with the temp agency. But because I was willing to go the temp agency route, it led me to not one, but two really good paying jobs. And then it led me here to where I am today. So don't turn your back on something because you think that it's temporary. Because I almost did that. And because I almost did that, you know, I could have lost out. So don't turn your back on something when, you know, you may have a potential to get in somewhere. If you Google temporary agencies for medical professionals in your area, a lot of them will pop up. I did that in the Dallas area. I'm not in Dallas, but in the Dallas area, there was a ton that popped up. And I recommend applying with not just one temp agency, but several, because sometimes these temp agencies actually get contracts for medical coding, and then they're going to need medical coders. Well, they may give you a test, and you need to at least pass that test before they give you an assignment to do. But as long as you can pass that, you know, you're halfway in. I'm just saying. EW says pre-certification specialist would give you lots of exposure to become a coder. Would you agree? I don't know what a pre-certification specialist is. What is that? Because sometimes they call things differently. So I don't know what it is. But yeah, don't work for free, guys. You've been technically trained. If you have your degree, make sure you're looking in your area to see what the salary starting rate is and go for that. Don't go for less. Because some of the things that I see, I'm like, really? I would be insulted for having a degree and going through all that. Authorizations. So like prior authorizations. That's what I've been talking about. Yeah, that would give you a lot of exposure to the codes, right? Because you have to know the procedure code and the diagnosis code for that procedure. So that way you can tell the insurance company. And not only that, you've got insurance company experience now too, because you're working with the electronic health record, which you can add to your resume. You've been working with insurance companies, again, which you can add to your resume. So those are types of things that you can pick up as a prior authorizations. You know, I was working with a young lady who was working as prior authorizations, and she was wanting to get into medical coding, and she knew a lot already. She knew a lot, and I was like, wow. You know, she had half of it down, but you know, it's just the coding part that she wanted to work on for herself, and so, you know, that's great. But yeah, prior authorization is a great place to start. So that would be good if you have that. But yeah, those are my thoughts. But yeah, if you're going to start off in risk adjustment, it's all diagnosis coding, but again, don't get stuck there. Use it to make your connections, get you some time in, and then move on, because you don't want to get to where you lose your ability to be able to code procedures and E&M. And while you may not like E&M, there's a lot of people that do not like E&M. While you may not like E&M is not the enemy. Honestly, it is actually fun when you start to work out E&M. And there's EM University, which has a lot of really good references and resources on that website, emuniversity.com. A very good website. Even I use it. The Novitas website I also use. So you can Google those and check them out. And the more you read those, the more it's going to make sense. If you have, is it in here? No, it's in the AMA CPT manual. They have in the back, they have the vignettes for E&M. So they have some for the ER, and I believe they have the Profi levels in there too as well. These vignettes are kind of giving you an idea of what falls into that E&M level. Kung Fu Ken says, I think you should be willing to relocate, even to other states, to be a coder, because getting in the door of this career is worth the future pay opportunities, and you can probably be remote later on. That is a great suggestion. I I haven't said it because when I would tell my story about having to move away, I had to move 8 hours away from my hometown. Do you know how much mail I got from people? Blue, I can't move. I never said for you to move. I was talking about my own story. But I got that so much. Blue, I can't move. And I'm like, I never said to move, you know? So that's why I kind of pick and choose what I say. But thank you for suggesting it. So, but yes, if you could move, absolutely. But of course, I know now I'm going to get that comment. Blue, I can't move. I didn't say move. I'm just saying that that's an option out there. It's just like when I recommended going to the temp agency yesterday as well. Again, I got that feedback. Well, no, I can't do that because I have bills. Well, I had bills too. And so it still was in my favor because I ended up getting those two positions. And moving, me being willing to move, which I did not want to move to the second position that I had. I did not want to move. I'll be honest with you guys. I did not want to move because that would have meant leaving my mom, who was sick at the time. So I didn't want to move, but my mom was like, no, you're going to go. And so I did what my mom told me. And now look. So sometimes you do have to take get out of that comfort zone. I would have loved to have stayed in my hometown. That was a comfort zone to me. This was actually me moving, was actually me being the first time on my own, moving away from home, being so far away. No family, no friends, no nothing. I knew nobody. I literally knew nobody going there. All I knew was where I had to report to at 7:30 Monday morning. That's all I knew. And I had maybe a weekend. I got there on a Saturday, and then Sunday, and then Monday morning I had to be at work. So you want to talk about like, I talked about it in my Christmas in July series about moving away, and that was my first time away from home. You know, when you're used to being around a lot of people and then you're all by yourself, yeah, that was a challenge. But now, in retrospect, now I wouldn't change it. I would not change one part of my journey. The only thing, if I could change any part of my journey, would be my mom being here. That would be the one thing that I would change, that she would be a part of this. And that she wouldn't just be here with me in spirit and energy. She would actually be here to see all of this. Coding, my career, she got to see the beginning part of it. She got to see me getting my career and actually doing something that I love. And she would see me get so excited at the thought of going to conferences, at the thought of, you know, being able to do this on a bigger scale someday. It's like, you know, teaching and stuff like that. You know, that was something that made her so happy because she got to see me start in a new career and know that I loved it, you know that it was something that I was enjoying, you know. But that was the one thing I wish she could be here. And then to see all this with YouTube and everything, and then like all these lights, and you know, sometimes when I look at this space, right, I leave for the day and I look back and I see the space, I see the tripod, I see all the lights, because I have 3 lights here. I don't know if you guys can tell, but I have 3 of those ring lights. And so I see all of these like boxes and wires, and it just looks crazy. And I see all these books, and then I think about all these things that I do with you guys every day. And I see you guys 5 days a week. You know, I come on here and do shows, and, you know, I still work a full-time job, and I still do all these things. And I have Patreon, and, you know, I do tutoring, and I do professional coaching and resume reviews and all these things. So, you know, it's this little crazy life that I've built for myself, and I enjoy it. It's not work, you know, which is always good. It's good to have that where you don't think of it as work, right? You just enjoy it. But yeah, that would be the one thing that I would wish. That would be the one thing that I would change, would be that she would be here. Hi, Clara. Thank you for checking in. Darn, I was hoping that pre-certification specialist was a spiffy title we could use after finishing school and before passing the test. Kung Fu Ken, do you see coders becoming hospital C-suite, CEO, CFO, COO? The degree holders, yeah. The RHIAs, yeah, definitely. Because those are the ones that are needed in the hospital to run the ship. Beth, I thank you for all you do. Oh, thank you. But yes, I would definitely not work for free. Okay, so guys, my thoughts on that: working for free, doing an internship somewhere just so that they can give you a letter of, oh yeah, they've had experience. It's not worth it, guys. Go where they're gonna value you. And while it may seem like it's so frustrating because everybody wants that, everybody wants experience, they're gonna say that because by and large, employers are lazy, right? If they have to choose between somebody they have to train versus somebody that already has experience, they can just throw in and send off and go. They're going to pick somebody that they can just send off and go rather than somebody that they have to actually train. This is why I tell coders all the time, make sure that you are going in there with your A game, that you have a strong grasp as much as you can of the coding part. Because while, yes, things are going to look a lot different on the outside when you get into the real world, the fundamentals are the same, right? Looking up the codes, making sure that you understand the guidelines so that you get to the proper codes. The book is going to lead you to the correct answer if you know how to use the book. Getting familiar with the book is half the battle. And what I mean by getting familiar with the book is actually opening up the book and flipping each page and looking at each page so you know where everything is in the book. You know, when I started doing those demonstration books on the CPT manual and on the ICD-10 CM manual and on the HCPCS book, I got the comment from a lot of people, I didn't know that was in the CPT book. In the appendixes, really? Why aren't you looking at your appendixes? Well, I was just concentrating on the front part, you know, on the diagnosis, I mean on the procedures part. I'm like, you gotta get familiar with the whole thing, because believe it or not, it's got a lot of information. It's got the anatomy plates in it, it's got the modifiers in it, and it's just chock full of information, guys. Denisha, epic specialist. Kung Fu Ken, even despite not being a physician or a nurse, it seems all higher management are RN or MD. Again, if you have your RHIA, Registered Health Information Administrator, those are the ones that are sitting at the top. Those are the ones that are in the executive suite. Those are the ones that run whole departments. Those are the ones that are with that. It's not just your RNs. It's not just your MDs. Your RHIAs are up there. You know, there are some facilities that absolutely have to have somebody who has an RHIA, and so that's that part of it. Unless I'm missing something that you're saying. But other than that, I mean, RHIA, if that's where you want to be in that executive suite, then that's what you need to get, RHIA. Or then you want to look at your master's degree. You want to look at that too. I mean, but that's what you want. If you want that level of of responsibility, you know. Denisha, you're asking about Epic Specialist, working with Epic. Is that what you're asking? Because I just see Epic Specialist. You're welcome, Ken. All right, so I did get it, you know. But let's see what else. Does anybody else have any questions? Because I've been talking nonstop. But yes, risk adjustment is a good place. It's a good place to start. And even if they're asking for experience, it's still okay. Sometimes some medical coding programs do teach risk adjustment specifically in their course. Some don't. You know, some are just teaching you just about the diagnosis coding and procedure coding. That's totally fine. You're still qualified to do that anyway for risk adjustment. You don't necessarily need the risk adjustment credential to get in risk adjustment. Sometimes I will see the CRC asked for, And a lot of times I won't. A lot of times they'll just say that they want a CPC or somebody with a CCS or a CCA. So that is what they have there. But look at the job listings, guys. Look at health information. Not necessarily health information management, because that's going to be like your leadership positions, but look at health information. When you Google search jobs for health information, they do kind of start giving you all those other alternative names, because sometimes these companies come up with these weird titles too. They'll say medical records technician, health information technician. They'll come up with something like that. So that way you can, okay, that's medical coder, I'm an RA coder with only RHIT and CCS. So are you planning on getting your RHIA? Because with the transition coming in 2027, they're going to make it possible for RHITs who already have it. I think you have to do like a certain amount of courses or whatever in order to sit for the RHIA. You might want to look into that. Clara says, difference between inpatient or outpatient, which one is best? I thought I did. Didn't I do it? I did an episode on that, especially for you. But we can go over it again. Ken, I think majority of my office has CPC and less so CCS. It doesn't necessarily mean that an employer won't take on somebody who has CCS. CCS is a gold standard of medical coding credentials. I don't care what anybody says. This is the one credential that says you have mastered both inpatient and outpatient. Okay? This is the one credential that a lot of people look for. And it really all depends kind of where you are. Sometimes people will say, well, we're looking for a CPC because the head of that department, or like the lead coder or whatever, or whoever's in charge, supervisor, has a CPC. So they tend to kind of look for people who are like them, right? CPCs. But it doesn't necessarily mean that if you have a CCS, they won't look at you. Or if you have a CCA, they won't look at you. Now, CCA, again, with a bad press. But again, if you're looking at the CCA and you understand what CCA actually covers, which is both inpatient and outpatient, this is just a baby version of the CCS. That's all that is. This is a baby version. It just says that you are entry level. That's it. And why people turn their back on it, I don't know. Because what they hear and what they think they know. This is why I held on to my CCA for so long. Because I wanted people to know that this is what a CCA can do. That's why I held on to it. I'm a CCSP now, Certified Coding Specialist, physician-based. And this is the mastery of the outpatient setting for AHIMA. So, you didn't know that, Ken? Oh, Ken, you need to check that out. I was also thinking about RHIA versus Healthcare Administration BS and versus Business Administration. If you're asking me my opinion, my humble opinion from what I've seen and what I know, go with the RHIA. Don't worry about the Healthcare Administration. That is not the same. That is not the same as the RHIA. And if I'm giving you my honest opinion, I think the RHIA has a little bit more weight to it. And you're almost there. You have your RHIT. You're almost there. I would go with the RHIA. Business administration, you should get into that if you don't want to do anything in healthcare. If you want to do something else, in another field, then absolutely, by all means, go for that. But if you're going to take the time and get your bachelor's degree, you may as well go for the RHIA, because like I said, you're almost there. And I believe I was reading that if you have the RHIT, they're going to make it where you take only a certain amount of classes and then you can sit for the RHIA. So yeah, you might want to check that out, because to me that would be more worthwhile. And especially if you're already in health information as it is, why would you want to switch if you are wanting to continue to be in this field? This is my 2 cents anyway. But yes. And inpatient or outpatient, which one is best? It depends on you, whatever you had training in. Some people start their careers in the outpatient setting and that's all they know. And then they start getting interested in the inpatient setting. So it really all depends. You know, if you have the opportunity to get training for the inpatient side, if you've only been trained for the outpatient side, and you want to have training for the inpatient side, inpatient is completely different. You got to know the ICD-10 PCS manual. Okay, yes, there's no CPT manual in that. There's no E&M level for inpatient coding, but there is the ICD-10 PCS manual, which is just as formidable opponent as that CPT manual. You know, so it is not easy. You have to know and understand your approaches. You have to know and understand the root operations of what you're doing on the inpatient side. So yeah, if you want to do inpatient coding, you're working with patients who are seeing inpatient. And while yes, you can do that on the outpatient side under the pro-fee umbrella, right? Because the pro-fee side, the professional, the doctor, has to go in and get paid for their professional services on the outpatient side, even though the patient is inpatient. But if you are working on the inpatient side, you are working for the facility. You are collecting all of these codes and everything for the facility, because the facility has to get paid for their service and their staff and all of their equipment and everything else that they're using, their supplies. And that is where the inpatient coders come into play. Okay. Ken, I was thinking about having an out for healthcare. To be honest, I'm 25 and I feel like I should get a bachelor's in general because a lot of my friends have theirs. So what is so wrong with you having an RHIA? And you have, this is the thing, maybe it's a younger generation thing, but in my opinion, okay, and this is my advice, don't look at your friends. Don't look at your friends, okay? Your friends, if they are not on your path, right? Don't worry about your friends. That's not to say that you can't do other things, but if your goal is to continue on in healthcare, you're only 25, you know, if your goal is to continue on in healthcare and to rise up in the ranks and things like that, RHIA is going to be great for you, you know. But as far as like having a general, you're not going to be able to move up into those RHIA type positions where you're over a whole department, because those positions, like over in the hospital, right? Those positions are going to require an RHIA. There are certain positions that require that RHIA degree. Now, that is not, if you have I'm going to get a general bachelor's degree. Okay, then what are you going to do with it? Business administration. Okay, well, are you running a business somewhere else? Because that's not health information. That's business. That's something else. You can't move up into an RHIA position with a bachelor's in business. You can't do that. So again, I would think about it. Don't worry about what your friends are doing, because unless your friends are supporting you, you shouldn't really follow what your friends are doing. I never understand that, because like all my friends are doing it, but what are you doing? You've got a lot going on, sir, for only being 25, having an RHIT and what is it, your CCS? That's really good. That's nothing to sneeze at either. But again, you're this close to having an RHIA, and then you want to go and get something else different. You're this close. And like I said, go and check out AHIMA, because they're having where they want their RHITs to transition, and so that's what they're wanting them to do, because they want to elevate what people are, because there's more RHIT degree holders than there is any other designation with AHIMA. So they were saying, okay, well, we need to raise up our leadership. That's what I would do. And I wouldn't worry about your friends and what they're doing, because that's not your path. Your path is this, and whatever it is that you want to do. That's not to say that you wouldn't be able to do other things if you have your RHIA. Certainly you would know about running your own business if that's really what you want to do. You don't even need a degree to run your own business, which is what I would think that you would need, right? That business degree for. But you know, if you're wanting to do something else, some other thing, then that's starting all over again. So it's something to think about. That's just my opinion. Maximus, hey Blue, I'm still here. I had my foot surgery Thursday, so I've been healing from that. Next Thursday, I will be back to my books. Well, good. And I hope that you heal quickly. And I wish you lots of healing energy. Ken, and I was thinking about taking that out in 20 years, maybe. Kimberly, did you ever doubt if medical coding was for you while you were in training? No. Honestly, I can say no. I was so excited when I actually got into it, when I actually got into the program and I started to learn that it was like, okay, I get it now. This is what I'm supposed to be doing. Did I always understand what I was reading? Did I always understand what I was doing? No. But did I ever doubt that it was not for me or that this was for me? No, I never doubted it. I never doubted that it was what I was supposed to be doing. I knew. And I knew that those feelings of doubt were going to come into play occasionally. But I never let that get too loud because of the simple fact that I had a goal in mind. And my goal was to get back up on my feet. You know, I was going through a divorce. I was unemployed, you know, and I was living at home with my mom, you know. So that was, and I was in my late 20s, you know. So I was just like, I just need to start my whole life again. You know, you have this idea when you're young, right? You get married, and I got married young. I was 22 when I got married. And so I was very young when I got married. And thinking, oh yeah, you know, this is what you're gonna do, and you know, and then you have to change paths. And so this was something that I could dive into. This was something that I could study, and I like to study, so that helped me a lot, because I didn't get those overwhelming feelings like I have to learn all this stuff. I knew I had to learn a lot, but I was okay with it because I had always been a reader. I wanted to be an attorney as a kid, so that was what I had always done during school, was read and write. Read, and I wrote a lot of papers, you know, because that's what I had heard that attorneys need to be able to do, is to be able to read a lot and to write a lot. So that's what I got good at, and that's what I wanted to do. But then when life changes and you have different things come into play, and they're like, oh. And then I have this gift because I went through the WIA, it's WIOA, Workforce Innovation and Opportunity Act. I went through that. They paid for it, and they just told me, hey, the deal is we'll pay for you to go to school, but you got to finish school and you got to find a job in the area that you were trained. I'm like, no problem, you know. And I said, okay, here you go. And I handed the school a voucher, and then they said, okay. And they sat me in front of a computer and said, here, you're going to learn it all on your own. Get ready, you know. So, but then when I finished school and I, you know, sat for my certification, passed in the first try, I was like, okay, here we go. But I did question myself, you know. This is some of the things that you can expect, you know. And that's all right, Kimberly. That's all right. Your age is nothing but a number. And trust me, there's people who start that are way older than you. Way older. And they have successful careers. And the CPC is scary. No, I don't regret it. Medical terminology will stick when you start to work with the codes. Thank you for sharing your story, Blue. You're welcome, Kyla. Hi, Flor. Thanks for the story. It helps. Well, I mean, when it comes to the CPCA, a lot of people, I mean, the test, if you're worried about the test, you know, the great thing about the CPC is that if you take it in person, you have that option of taking the free retake. But if you take it at home, then you only get the one shot to take it. And I think if you get really nervous, that's a really great option, right? To be able to say, okay, well, I didn't do so well the first time, let me go back and take it again. And then having that option and it being okay that you can take it again. That's always good. You want to have those options wherever you can get them. But it is about believing in yourself after a while. You know, when it comes to these tests and your knowledge base and what you know, it will come with time. That confidence will come with time. You know, just like when you're a little kid, they're not expecting you to read like books like Tolstoy or anything like that when you're a little kid in kindergarten. They're teaching you like Little Red Riding Hood, right? Because it's the building blocks. This is a completely different language. Okay, this is a completely different language. Medical coding, reading medical documentation, it is completely different. It's like when these providers get to speaking, they get to speaking and it's a different language altogether. So it's not like it's something that is so easy for even people who are not coders to get, right? It is something that takes time, and you will get it after a while. And what you don't understand, then you need to be okay with yourself to look it up and be like, okay, well, I didn't understand this word. What does this word mean? When I started coding for, and the manager that gave me a challenge, she assisted my new boss into re-putting me into a different clinic. So they put me into the same-day surgery clinic, which is okay. But I had not done same-day surgeries. I had been more proficient in like prophy coding and all these other clinics. So same-day surgery was something new for me. That's fine. The one that I struggled with the most in the beginning was the meniscus surgeries. So I started to watch the meniscus surgeries on YouTube just to listen to like the words and the language and everything else. And then watching them actually go in and do that started making the notes make a whole lot more sense, those op notes. So I was like, that's how I do. So anytime I get stuck on anything like that, that's a good way to learn and to kind of get it after a while. Because when you start to understand what's going on with those op notes, trust me, it's going to make coding those a lot easier. Desiree, yes, indeedy. I'm in my 60s and there ain't no stopping me. There you go. The lady that I knew, she was age 61 when I finished school. And she's still a coder today. And I've been a coder for over 10 years. I've been a coder since 2008. She's still going. She's a feisty woman. Very feisty. Oh no, not that question. Margaret, why you do this to me? Maximus, I ordered the practice tests D, E, and F from AAPC, and they're so much more difficult from A, B, and C. But that's okay, they're teaching me new things. There you go. The more practice you get, the better off you are. I only recommend AHIMA or AAPC. There are some organizations that are out there that offer the free voucher for a certificate, okay? And some I have seen that they charge money for it. My challenge to you is, if you're looking at that other one that is not AHIMA or AAPC, to look and see if that certificate is being asked for in the job listings. And I'm pretty sure that you'll be shocked to find out that it's not. So that is what I will say about that. And this is why I will say only that I only recommend getting certified through AHIMA or AAPC. If you are looking to be taken seriously as a medical coder, if you are looking for the credential that employers are looking for, they are looking for two associations, right? Either AHIMA or AAPC. They want you to be certified through AHIMA or AAPC because these are the heavyweights, if you will, of medical coding. So these are the leaders of the industry. These are the heavyweights. So that is who you want to get certified through. I will say again, I only recommend AHIMA or AAPC. Anything else that is not them, I would strongly recommend that you reconsider, and I would strongly recommend that you do your research in your area to see if anyone is asking for it, which I'm sure you will see that they are not. Pamela, because we have positions open for... Why do I only get half of questions? I feel like I only get half of questions lately. I'm like, because we have positions open for what? Well, while I wait for that. But yes, that was my thoughts and opinions for today. But yes, that is what I would recommend. If you are really wondering about that, look in your area, and I'm sure that you'll see. I've been scolded so many times from people from the schools. Oh, and I was like, really? Did you look in your area? Kyla, is coding an isolation position, or are you ever coding with someone? I previously worked in medical records, and I was alone for majority of my shift, jamming to my music. It depends. It depends on where you're working. For some places, when I first got here, right, they had us housed in a room. We were in this very small room. There was 20 of us, 20 women in bullpens, right? So there was a lot of us, and we were always around each other. Now that we're in this big, beautiful new hospital that they built a few years ago, they made it to where the coders had space in the clinics, because they wanted the coders to be close to the staff, so that way they can ask questions, and it would be better for the documentation, it would be better for the provider, because, excuse me, sometimes providers want to have that communication. It really all depends. But with that, it came, well, people are housed two to a room. Some people have their own space. I have my own space. So it really all depends. Sometimes you're in a room with a bunch of people, and sometimes you are in your own office, and sometimes you are sharing with a partner. I had a partner for many years. She moved on to another position, and I have my own space. So, it really all depends on where you're working. But yeah, largely you are working by yourself, because even if you are in a room full of people, you still need to have your headphones on so you can concentrate on reading whatever you're doing. Because you have a production standard to meet, and you have an accuracy standard to meet. And so us being 20 in a room, it was a challenge sometimes, because the room would get loud, and if there's nobody there to control the room can kind of get out of control. So but yeah, again, it is all on your environment, so depending on where you are. If you're working at home, obviously you're at home. But if you are working in a place, you may be in a room with people, you may not, and sometimes it's just a big room, and they'll have like bullpens, little cubicles everywhere, and that could be it too. Our inpatient department is like that. They have a big room, and they have all the records on the walls, and then they have like in their little cabinets and stuff, and then they have the coders desks in there, so it's kind of like a little maze, kind of neat. But again, it's really wherever your facility, however they have it. So yes, that is my chat for today. We went long, but that's okay. I'm glad y'all have y'all's questions. I have plenty of videos, so if you wanted any in-depth details about like inpatient versus outpatient, I did do that video. And I'm going to go ahead and wrap it up. So if you haven't had a chance to subscribe already, I hope that you do. Share this video if it helped you. Like if you haven't already. And I will go ahead and see y'all next time. Bye.